What made you interested in PACU nursing compared to other specialties?
I was drawn to PACU nursing because it combines acute, high-stakes care with continuous patient interaction. Early in my clinical rotations, I realized that the PACU environment allows nurses to make immediate, tangible differences in patient outcomes. I recall caring for a post-operative patient who suddenly developed hypotension. I quickly assessed airway, breathing, and circulation, collaborated with the anesthetist, and implemented interventions that stabilized the patient within minutes. That immediacy of impact, where critical thinking, vigilance, and teamwork directly prevent complications, was profoundly rewarding. I'm also attracted to the balance between technical and holistic care. Monitoring complex post-anesthesia physiology, managing pain, and anticipating complications require meticulous attention to detail, but the role also demands empathetic communication, often with patients emerging disoriented or anxious. I take time to reassure patients, explain procedures, and provide support, which improves both safety and recovery. Additionally, PACU nursing offers constant learning. Each patient presents a unique combination of surgical procedure, anesthesia type, and comorbidities, keeping my assessment and prioritization skills sharp. Compared to other specialties, PACU provides a structured yet dynamic setting where I can combine clinical expertise with compassionate care, making a real difference during a critical phase of recovery.
Tell me about your experience with different types of anesthesia.
I have extensive experience caring for patients across all anesthesia types, ensuring safe recovery and monitoring from induction to discharge. With general anesthesia, I manage patients emerging from surgery, closely monitoring airway, breathing, and hemodynamics. I once cared for a post-cardiac surgery patient who required careful fluid and vasopressor management during emergence. Timely intervention prevented complications. For regional anesthesia, including spinal, epidural, and nerve blocks, I monitor for hypotension, motor or sensory deficits, and pain control. I remember an orthopedic patient after a femoral nerve block. I coordinated pain assessment and safe mobilization once motor function returned, promoting faster recovery and reducing opioid use. During MAC, I support procedures where patients remain spontaneously breathing but sedated, such as endoscopic or minor ENT surgeries. I monitor sedation depth, oxygen saturation, and airway status, ready to intervene if oversedation occurs. With local anesthesia, I assist in minor procedures, ensuring patient comfort, understanding, and stable vitals. Across all anesthesia types, my focus is on early recognition of complications, individualized monitoring, and clear communication with patients and the multidisciplinary team to ensure safe, smooth recovery.
What do you consider the most challenging aspect of being a PACU nurse?
The most challenging aspect of PACU nursing is managing the unpredictability and acuity of patients immediately post-surgery, often while their physiology is unstable. Every patient presents a unique combination of surgical stress, anesthetic effects, and comorbidities, requiring rapid assessment and timely intervention. I once cared for a patient who developed sudden hypotension and oxygen desaturation after extubation. Promptly assessing airway, breathing, and circulation, adjusting monitoring, and coordinating with the anesthetist stabilized the patient quickly, reinforcing the need for constant vigilance. Managing patients' anxiety and disorientation is another challenge. Many are confused, in pain, or frightened. I have learned to maintain calm reassurance, explain procedures simply, and involve family where appropriate, which enhances cooperation and safety. Simultaneously, balancing multiple high-acuity patients demands prioritization, delegation, and organization, particularly during peak periods. Despite these challenges, they are also what make PACU rewarding. The ability to stabilize patients during a vulnerable stage, combine technical skill with empathy, and collaborate closely with the team is both fulfilling and motivating.
How do you stay current with the latest peri-anesthesia guidelines?
Staying current with peri-anesthesia guidelines is essential to safe PACU practice, as standards directly influence patient monitoring, discharge criteria, and complication management. I take a structured and practical approach to keeping my knowledge up to date. I regularly review evidence-based guidelines from recognized bodies such as ASPEN and align them with my unit's policies and protocols to ensure my practice reflects current recommendations rather than routine habits. In my previous role, our unit updated its PACU discharge criteria to better reflect physiologic readiness rather than time-based recovery. I took the initiative to review the updated standards, attend an in-service session led by the anesthesia team, and apply the changes in daily practice. This included more consistent use of standardized scoring tools, closer respiratory monitoring in high-risk patients, and clearer documentation. As a result, handovers to the ward became more structured, and we saw fewer post-transfer complications related to pain and airway issues. I also stay current by participating in continuing education, attending workshops or webinars related to anesthesia and recovery care, and engaging in clinical discussions with anesthetists and senior PACU nurses. Reviewing incident reports and audit outcomes has also helped me identify areas where guidelines need to be reinforced in practice. Most importantly, I integrate new knowledge deliberately, reflecting on how updates affect patient safety, workflow, and interdisciplinary communication. By combining formal guidelines with real-world application and team collaboration, I ensure my peri-anesthesia practice remains current, consistent, and aligned with international standards.
Where do you see yourself professionally in 5 years?
In 5 years, I see myself as a highly competent and trusted PACU nurse with advanced clinical expertise and a strong professional voice within the peri-anesthesia team. My primary goal is to deepen my critical care and peri-anesthesia knowledge so I can manage complex post-operative patients with confidence, particularly those with multiple comorbidities or higher anesthesia risk. I aim to be recognized as someone colleagues rely on for sound clinical judgment, calm decision-making, and patient advocacy during high-acuity situations. Alongside clinical growth, I intend to pursue formal education and certifications relevant to peri-anesthesia or critical care nursing, ensuring my practice remains aligned with international standards and evidence-based care. In my previous roles, I have naturally taken on informal leadership responsibilities, such as supporting junior nurses during busy shifts, assisting with complex recoveries, and reinforcing safe recovery protocols. Building on this, I see myself stepping into a senior PACU or charge nurse role where I can contribute to unit efficiency, staff development, and quality improvement initiatives. I'm also interested in participating in clinical audits, guideline implementation, and education sessions related to anesthesia recovery, pain management, and patient safety. I believe these activities strengthen team performance and directly improve patient outcomes. Ultimately, I want to remain clinically grounded while expanding my leadership and teaching responsibilities. My long-term vision is to grow within the PACU specialty, contribute meaningfully to patient safety and team excellence, and continue developing as a reflective, evidence-driven nurse who adapts to the evolving demands of peri-anesthesia care.
How do you assess a patient's readiness for discharge from the PACU?
Assessing a patient's readiness for discharge from the PACU requires a systematic, criteria-based approach that prioritizes safety while accounting for individual risk factors. I begin by ensuring the patient has achieved physiological stability rather than relying on time-based recovery. This includes confirming a patent airway, adequate oxygenation on appropriate support, stable respiratory patterns, and hemodynamic parameters that are within acceptable limits compared to their baseline. I closely evaluate the patient's level of consciousness, ensuring they are awake or easily arousable, able to maintain their airway, and oriented as appropriate for their age and condition. Pain control is another key factor. I assess both pain scores and functional comfort, confirming that analgesia is effective without causing excessive sedation or respiratory compromise. I also monitor for nausea and vomiting, ensuring symptoms are well controlled to reduce aspiration risk and improve comfort. Motor and sensory function are assessed carefully, particularly in patients who have received regional or neuraxial anesthesia. I ensure there is appropriate return of movement and sensation, and that any residual effects are documented and communicated clearly during handover. Surgical site assessment is also essential, including checking for bleeding, drains, urine output, and overall fluid balance. In one instance, a patient appeared stable but had borderline oxygen saturation on room air. By extending observation and adjusting oxygen therapy, we avoided a premature transfer and potential respiratory deterioration on the ward. Finally, I ensure documentation is complete and handover is structured using standardized discharge criteria and clear communication with the receiving team. This comprehensive approach supports safe, timely transfers, and continuity of care.
What are the most common post-operative complications you monitor for?
In the PACU, I closely monitor for post-operative complications that can develop rapidly and significantly affect patient outcomes. The most common and high-risk issues involve the airway, breathing, circulation, pain control, and neurological status. Early identification and prompt intervention are critical during this recovery phase. Respiratory complications are a primary concern, particularly airway obstruction, hypoventilation, hypoxia, and aspiration. These risks are higher in patients who have received general anesthesia, opioids, or have conditions such as obesity or sleep apnea. I continuously assess respiratory rate, oxygen saturation, breath sounds, and level of consciousness, intervening early with airway positioning, oxygen therapy, or escalation to the anesthesia team if needed. Hemodynamic instability is another frequent issue, including hypotension, hypertension, dysrhythmias, and bleeding. I monitor vital signs closely, assess surgical sites and drains, and evaluate urine output and fluid balance. I recall caring for a patient whose blood pressure dropped progressively despite appearing comfortable. Early recognition and fluid management prevented further deterioration. Pain and nausea are also common post-operative concerns. I assess pain using appropriate scales and evaluate the effectiveness and side effects of analgesia, balancing comfort with safety. Post-operative nausea and vomiting are managed proactively to reduce aspiration risk and improve recovery. Neurological changes such as delayed emergence, agitation, or confusion, particularly in older adults, require careful assessment and reassurance. I also monitor for complications related to regional anesthesia, including motor weakness or sensory deficits. By maintaining a systematic assessment approach and anticipating risk factors, I ensure complications are identified early, managed effectively, and communicated clearly to support safe patient recovery and transfer.
What is your process for managing a patient who wakes up in extreme pain despite receiving meds in the OR?
When a patient wakes up in extreme pain despite receiving analgesia in the operating room, my priority is to perform a rapid, structured assessment while providing reassurance. I begin by assessing the patient's airway, breathing, and circulation to ensure physiological stability, then evaluate the nature, location, and intensity of the pain using an appropriate pain scale. I also review the anesthetic record to understand what analgesics were given, their timing, and whether regional techniques were used. I consider contributing factors such as surgical site issues, positioning-related pain, bladder distension, anxiety, or inadequate analgesic coverage. In one case, a post-abdominal surgery patient reported severe pain immediately on arrival in PACU despite intraoperative opioids. On assessment, vital signs were elevated, and the patient was visibly distressed. I provided calm reassurance, optimized positioning, and initiated non-pharmacological measures such as controlled breathing while preparing to escalate pharmacological management. I promptly communicated my assessment findings to the anesthetist, advocating for additional or alternative analgesia. This included titrated intravenous opioids under close monitoring, adjuncts such as paracetamol or NSAIDs where appropriate, and consideration of regional or local anesthetic top-ups if available. Throughout this process, I closely monitored sedation level, respiratory status, and hemodynamics to balance pain relief with safety. I reassessed pain frequently after each intervention, documenting the response and adjusting the plan as needed. Once pain was controlled, I reinforced patient education, explaining what to expect and when to request help. This structured, patient-centered approach ensures effective pain management while minimizing the risk of oversedation or respiratory compromise in the PACU.
How do you handle a patient experiencing post-operative nausea and vomiting?
When managing a patient experiencing post-operative nausea and vomiting, my approach is systematic, proactive, and focused on both symptom relief and patient safety. I begin by assessing the severity and timing of symptoms, reviewing the anesthetic record to identify risk factors such as opioid use, volatile anesthetics, history of motion sickness, or previous PONV. I also assess vital signs, airway reflexes, and level of consciousness to reduce the risk of aspiration. Initial management includes non-pharmacological measures such as positioning the patient laterally if drowsy, maintaining head elevation, providing supplemental oxygen, and minimizing strong smells or unnecessary movement. I reassure the patient, as anxiety can worsen nausea and encourage slow, controlled breathing. If symptoms persist, I escalate pharmacological management in line with protocols. I administer prescribed antiemetics promptly and monitor the patient's response. In one instance, a patient continued vomiting despite initial treatment. After reassessment, I communicated with the anesthetist, who prescribed a second antiemetic from a different class. This combination approach effectively resolved symptoms and improved the patient's comfort. I also review pain management, as poorly controlled pain or excessive opioids can contribute to PONV. Where appropriate, I support a multimodal analgesia approach to reduce opioid requirements. Hydration status is assessed and optimized, as hypovolemia can worsen nausea. Following symptom control, I continue close observation, reassessing nausea scores and ensuring the patient can tolerate oral fluids if appropriate. Clear documentation and handover are essential, particularly if symptoms recur. This structured approach minimizes complications, improves patient comfort, and supports a smoother recovery and discharge from the PACU.
Describe your experience with advanced cardiac life support in a recovery setting.
My experience with advanced cardiac life support in a recovery setting has reinforced the importance of early recognition, clear communication, and coordinated team response. In the PACU, patients are particularly vulnerable to rapid deterioration due to residual anesthetic effects, airway compromise, or underlying comorbidities, so maintaining ACLS readiness is essential. I have participated in multiple emergency responses in the recovery area, including acute bradycardia, hypotension progressing to cardiac arrest, and peri-arrest arrhythmias. In one situation, a post-operative patient developed sudden severe bradycardia and hypotension shortly after arrival in PACU. I recognized the change promptly through continuous monitoring, initiated immediate assessment, and called for assistance while ensuring airway support and high-flow oxygen. I assisted in preparing emergency medications, supported chest compressions when required, and ensured defibrillation equipment was ready. During these events, I focus on maintaining my assigned role, whether that involves monitoring vital signs, administering medications as directed, documenting events in real time, or communicating updates to the team. I am comfortable using emergency equipment such as defibrillators, emergency drug trolleys, and airway adjuncts, and I understand the importance of adhering to ACLS algorithms while adapting to the clinical context. Following stabilization, I assist with post-event care, including close hemodynamic monitoring, documentation, and structured handover to higher acuity units if escalation is required. I also participate in debriefings, reflecting on what went well and identifying areas for improvement. My ACLS experience in the PACU has strengthened my ability to remain calm under pressure and contribute effectively to life-saving interventions in a recovery setting.
How do you monitor and assess a patient's level of consciousness as they emerge from anesthesia?
Monitoring a patient's level of consciousness during emergence from anesthesia requires continuous assessment, patience, and an understanding of how different anesthetic agents affect recovery. I begin observing the patient as soon as they arrive in PACU, noting their response to verbal and tactile stimuli, eye-opening, and ability to follow simple commands. These early responses help me gauge the progression from deep sedation to full consciousness. I use standardized assessment tools alongside clinical judgment to ensure consistency and safety. This includes assessing orientation to person, place, and time when appropriate, and monitoring for signs of delayed emergence such as prolonged drowsiness, minimal response to stimuli, or unexpected agitation. I correlate these findings with vital signs, oxygenation, and pain levels, as changes in consciousness can signal hypoxia, hypercapnia, hypotension, or medication-related effects. In one instance, a patient remained excessively drowsy longer than expected following general anesthesia. I ensured airway patency, increased monitoring frequency, reviewed the anesthetic record, and communicated my concerns to the anesthetist. Further assessment revealed residual sedative effects, and with supportive care and extended observation, the patient recovered safely without complications. I also monitor for emergence delirium, particularly in older adults, addressing it with reassurance, a calm environment, and appropriate pain control. Throughout recovery, I document changes clearly and reassess frequently, especially after interventions. By combining structured assessment with close observation and timely escalation, I ensure patients regain consciousness safely and are appropriately prepared for discharge from the PACU.
Tell me about a time a patient's condition deteriorated suddenly. What was your immediate action?
I recall caring for a post-operative patient in the PACU who initially arrived stable following abdominal surgery under general anesthesia. About 10 minutes into recovery, I noticed a sudden change in vital signs, with rapidly dropping oxygen saturation and increasing respiratory effort. The patient became restless and less responsive, which immediately signaled a potential airway or respiratory complication. My first action was to ensure airway patency and assess breathing and circulation. I repositioned the patient, applied high-flow oxygen, and performed a focused assessment while calling for immediate assistance. Continuous monitoring was already in place, allowing me to quickly identify the trend rather than relying on a single reading. I notified the anesthetist promptly, clearly communicating the patient's condition, recent changes, and my immediate concerns. While awaiting further support, I prepared emergency equipment and ensured intravenous access was patent. Under direction, additional interventions were initiated, including airway support and medication adjustments. Throughout the event, I maintained a calm environment, delegated tasks to available staff, and reassured the patient to reduce anxiety, which was contributing to increased respiratory distress. The patient's oxygenation and responsiveness improved once the underlying issue was addressed, and they were stabilized without further escalation. Following the event, I continued close observation and completed detailed documentation, ensuring a clear handover to the next level of care. This experience reinforced the importance of constant vigilance, early recognition of subtle changes, and decisive action in the PACU. Acting quickly, communicating effectively, and working cohesively with a multidisciplinary team were key to preventing further deterioration and ensuring a safe outcome for the patient.
Describe a situation where you had to advocate for a patient with a surgeon or anesthesiologist.
I recall caring for a post-operative patient in the PACU who had undergone major orthopedic surgery under general anesthesia. Although the patient met several discharge parameters, I noticed persistent borderline oxygen saturation and increasing drowsiness despite minimal pain medication and recovery. Based on my assessment, I was concerned that transferring the patient at that stage could place them at risk of respiratory compromise on the ward. I reviewed the anesthetic record, reassessed the patient's airway, respiratory effort, and sedation level, and confirmed that the oxygen requirement had not reduced as expected over time. I then approached the anesthesiologist, clearly outlining my observations, the trends and vital signs, and why I felt the patient was not yet ready for transfer. Rather than presenting this as a challenge, I framed it as a patient safety concern, supported by objective data and recovery criteria. Initially, there was an expectation that the patient could be transferred with supplemental oxygen. However, I calmly explained that the patient was still intermittently obstructing their airway when drowsy and had not yet demonstrated stable oxygenation on minimal support. I suggested extending PACU observation and reassessing after a defined period, which the anesthesiologist agreed to. During the extended monitoring, the patient experienced a brief desaturation episode, confirming the initial concern. Further interventions were implemented, and the patient was stabilized before transfer. This experience highlighted the importance of professional advocacy, clear communication, and confidence in clinical judgment. By focusing on patient safety and using objective assessment rather than opinion, I was able to support a safer outcome and strengthen collaborative decision-making within the team.
Tell me about a time you had to deal with an emergence delirium patient.
I once cared for a middle-aged patient in the PACU who developed acute emergence delirium following general anesthesia for abdominal surgery. On arrival, the patient was disoriented, attempting to remove monitoring equipment, and became physically agitated, posing a risk to themselves and staff. My immediate priority was safety. I ensured the airway was protected, oxygen was applied, and potentially harmful equipment was moved out of reach. I called for assistance early so that adequate staff were present, which helped maintain control of the situation without escalating the patient's distress. I positioned myself within the patient's line of sight and used a calm, firm voice, repeatedly reorienting them to where they were and reassuring them that they were safe. I quickly assessed possible contributing factors, including hypoxia, pain, bladder distension, and residual anesthetic effects. Vital signs were monitored continuously, and I noted elevated heart rate and blood pressure, suggesting both agitation and discomfort. I communicated my assessment to the anesthesiologist, who prescribed appropriate pharmacological support to settle the patient while maintaining airway safety. Throughout the episode, I coordinated with the team to ensure minimal restraint was used and only as a last resort, prioritizing dignity and patient safety. Once the delirium resolved, the patient became calm and cooperative, with stable vital signs. Following recovery, I continued close observation and documented the event clearly, including triggers, interventions, and response. This experience reinforced the importance of early recognition, calm communication, team coordination, and addressing reversible causes promptly to manage emergence delirium safely and effectively in the PACU.
Describe a time you made a clinical error. How did you handle it and what did you learn?
Early in my PACU practice, I experienced a situation that reinforced the importance of vigilance and transparency. I was caring for a post-operative patient recovering from general anesthesia who required regular pain assessments. During a busy period with multiple admissions, I administered prescribed analgesia appropriately, but delayed reassessing the patient's pain score within the expected time frame due to competing clinical demands. Although the patient remained physiologically stable, they later reported that their pain had escalated sooner than anticipated. As soon as I realized the delay, I reassessed the patient immediately, addressed their pain, and ensured they were comfortable. I informed the anesthetist of the situation, documented the sequence of events accurately, and reported the incident according to unit policy. I also explained the delay to the patient, acknowledged the lapse openly, apologized, and reassured them that their comfort and safety were my priority. The patient responded positively to the honesty and felt reassured once their pain was effectively managed. After the shift, I reflected on the contributing factors, including workload pressure and task prioritization. I discussed the incident with a senior nurse, who helped me review strategies to prevent recurrence. As a result, I adopted a more structured approach to reassessment, using reminders and aligning pain reviews with routine observations, even during peak activity. I also became more proactive about asking for support when managing multiple high-acuity patients. This experience taught me that clinical errors, even minor ones, must be addressed promptly, transparently, and professionally. It strengthened my commitment to patient-centered care, accurate documentation, and reflective practice, and ultimately improved my time management and prioritization skills in the PACU setting.
Tell me about a time you had to prioritize multiple high-acuity patients at once.
Working in the PACU often requires managing several high-acuity patients simultaneously, and one particular shift stands out. During a peak recovery period, 3 post-operative patients arrived within a short time frame following major surgeries. One patient was hypotensive after general anesthesia, another was experiencing significant pain with rising heart rate and blood pressure, and the third had borderline oxygen saturation with a history of obstructive sleep apnea. I immediately performed rapid, focused assessments on all 3 patients to identify the most immediate risks. The hypotensive patient became my first priority due to the potential for rapid deterioration. I ensured continuous monitoring, assessed fluid status, and notified the anesthetist while initiating prescribed interventions. At the same time, I delegated specific tasks to colleagues, asking one nurse to monitor the patient with sleep apnea closely and another to assist with analgesia administration and observation for the patient in pain. Once the hypotensive patient began to stabilize, I reassessed the others, adjusting oxygen therapy for the high-risk respiratory patient and coordinating additional pain management for the patient in distress. I maintained clear communication with a multidisciplinary team, providing concise updates and ensuring everyone understood their role. Throughout the process, I continually reprioritized based on real-time changes rather than fixed assumptions. All 3 patients stabilized without further escalation, and safe transfers were achieved. This experience reinforced the importance of rapid assessment, effective delegation, and constant reevaluation in high-pressure environments. It also highlighted that prioritization is dynamic in the PACU, requiring both clinical judgment and teamwork to maintain patient safety when multiple high-acuity recoveries occur simultaneously.
How do you handle a conflict with a coworker or a surgeon in the high-stress environment of the OR/PACU?
In a high-stress environment like the OR or PACU, I believe conflict must be managed calmly and professionally, with patient safety as the central focus. I recall a situation in the PACU where a surgeon was frustrated about a perceived delay in transferring a post-operative patient. The unit was extremely busy and tensions were high, which made communication more challenging. Rather than responding defensively, I acknowledged the surgeon's concern and calmly explained my clinical assessment. The patient had ongoing oxygen requirements and intermittent airway obstruction when drowsy, which meant they did not yet meet discharge criteria. I supported my position with objective observations, recovery parameters, and current PACU protocols. Keeping my tone respectful and factual helped shift the conversation away from emotion and toward patient safety. Once the immediate situation was stable, I followed up privately with the surgeon to clarify expectations and ensure we had a shared understanding of discharge readiness. This discussion helped prevent similar misunderstandings in future cases and strengthen professional collaboration. When conflict arises with colleagues, I use the same approach. I listen actively, seek to understand their perspective, and communicate my own concerns clearly without assigning blame. If the issue cannot be resolved immediately, I involve a senior nurse or charge nurse to maintain workflow and safety. Through experience, I have learned that addressing conflict promptly, respectfully, and with evidence-based reasoning reduces tension and maintains trust. By keeping discussions patient-focused and professional, I'm able to navigate high-pressure situations effectively while preserving teamwork and a safe clinical environment.
What does a high-performing PACU team look like to you?
To me, a high-performing PACU team is one that delivers consistently safe, efficient, and patient-centered care through strong communication, mutual trust, and shared accountability. In such a team, roles are clearly understood, yet flexible, allowing members to support one another seamlessly during periods of high acuity or rapid patient turnover. I have worked in recovery units where team members communicated proactively, sharing critical information early and anticipating potential issues rather than reacting to them. For example, anesthetists, surgeons, and nurses collaborated closely during handover, ensuring that risks such as airway concerns, pain management challenges, or hemodynamic instability were clearly identified. This level of coordination reduced delays, prevented complications, and improved continuity of care. A high-performing PACU team also demonstrates situational awareness. Nurses continuously reassess not only their own patients but the unit as a whole, stepping in to assist colleagues when a patient deteriorates or when workload suddenly increases. There is a culture where asking for help is encouraged and seen as a strength rather than a weakness. Equally important is psychological safety. Team members feel comfortable speaking up, questioning decisions respectfully, and advocating for patients without fear of blame. I have seen how this environment leads to earlier escalation of concerns and better outcomes. Finally, high-performing teams are committed to learning and improvement. They reflect after critical incidents, participate in audits and education, and adapt practice based on evidence and guidelines. This combination of teamwork, communication, accountability, and continuous learning defines excellence in the PACU and directly translates into safer patient recovery and better overall outcomes.
How do you provide effective discharge instructions to a patient and family who are anxious or overwhelmed?
When providing discharge instructions to an anxious or overwhelmed patient and their family, I focus on clarity, reassurance, and ensuring understanding rather than simply delivering information. I begin by assessing their emotional state and readiness to receive instructions, as anxiety can significantly reduce retention. I use a calm tone, simple language, and break information into manageable sections instead of presenting everything at once. I prioritize the most critical points first, such as pain management, warning signs that require medical attention, and immediate post-discharge restrictions. I relate instructions to what the patient is likely to experience at home, which helps make the information more practical and less abstract. For example, when discharging a patient after day surgery, I explained expected drowsiness and nausea in advance so the family would not panic if these symptoms occurred. I actively involve both the patient and family, encouraging questions and checking understanding by asking them to repeat key points in their own words. This approach often reveals misunderstandings that can be corrected immediately. Written instructions are reviewed together rather than handed over without explanation, and I highlight specific sections to refer to later. In one situation, a family appeared visibly distressed about managing pain at home. I demonstrated how to use the prescribed medication safely, clarified dosing schedules, and discussed non-pharmacological comfort measures. Their anxiety reduced noticeably once they felt confident in what to do. By combining empathy, structured communication, and confirmation of understanding, I ensure discharge instructions are effective, reduce anxiety, and support safe recovery at home.
Give an example of a time you had to overcome a communication barrier with a patient or their family.
I once cared for a patient in the PACU who spoke very little English, while their family spoke some English but were anxious and had limited medical understanding. The patient had undergone major abdominal surgery and was experiencing moderate pain and confusion on emergence, which made communication even more challenging. My priority was to ensure they understood their condition, pain management plan, and safety instructions while reducing anxiety. I began by assessing the patient's and family's baseline understanding and preferred language, then engaged a professional interpreter rather than relying solely on the family. I used simple, clear language, spoke slowly, and paired explanations with visual aids to illustrate post-operative care, including pain control, positioning, and warning signs that required urgent attention. I checked understanding frequently by asking the patient and family to repeat instructions in their own words, clarifying any misconceptions immediately. I also paid attention to nonverbal cues, such as facial expressions, gestures, and body language, which helped me gauge pain, confusion, or hesitation even when words were limited. For example, the patient's grimacing indicated inadequate analgesia, prompting timely escalation to the anesthetist for additional pain management. By combining interpreter support, visual aids, repetition, and empathetic engagement, I was able to ensure the patient and family understood essential care instructions and felt reassured. This experience reinforced the importance of adapting communication strategies to meet diverse patient needs, maintaining patience, and prioritizing safety, ultimately resulting in a smoother recovery and reduced post-operative anxiety for both the patient and their family.